Well, Vicki, thank you very much, and team, for getting us together today to end our Lunch and Learn series for 2022. It's my honor to be able to try to provide a summary of the presentations that we heard, some of the key concepts that we learned, and also to review some of the tools that were presented, all with the bottom line we'll drop right to the bottom to increase hypertension control rates, not only in our individual communities, our regions, and also hopefully even our country. It's really important first to look back before we go forward and summarize. This is the curriculum for the Lunch and Learn series that is completing today with our overview for 2022. And I was struck when I put the presentations together on one piece of paper. You know, you see them in staccato, in silos, and then when you put them all together, it really struck me the breadth of the presentations, obviously not only encompassing hypertension, but primary care, diabetes, chronic kidney disease, healthcare disparities, and aligning with other organizations, as you will. And you can see the individual presentations, and there were 9 of them, if you will. Also, it struck me the presenters. Our faculty are world-renowned, internationally renowned, mostly primary care based. And really, it was an honor to have all of them, and we owe them a debt of gratitude. And I will extend the debt of gratitude to each and every one of them following the completion of our series. Without the faculty, of course, we wouldn't be even discussing the summary. Next slide, Vicki. Let's try to go ahead and touch on some of those presentations. Obviously, we can't redo all of them or summarize all of them with any great detail, but I took the leeway, and I took the prerogative to look at for some key points from each and every one of them. But the first key point was the collaborative. Why are we even doing this? Always ask why. Whenever somebody asks you to do something, it's the most common word a 4-year-old utters. I learned that from elementary teachers, et cetera, when we had our children. So always ask why. So why do we need HEARTS? Why do we need the Lunch and Learn series, and why do we need to come together as a team? And it's because of this gentleman, Mr. Carter, was an industrialist in the 80s and early 90s. He sensed that American industry needed to change, even though they were doing quite well, making lots of money and doing well for stockholders. But he saw storm clouds on the horizon, and he developed an 8-point system that is in use today for organizational change in order for it to be successful with a great deal of percentage rate, if you will. He listed these 8. However, I have highlighted the first one. The first recommendation from Mr. Carter for successful organizational change was to establish a sense of urgency, a so-called burning platform. And then the other 7 you can see on this slide, and you can review at your leisure. So that is what that's what we started out about 4 or 5 months ago. We started with the burning platform, the sense of change, and the why. Next slide. So why are we all here? So what is this sense of urgency? And it's easy. We all know it, but it's also interesting and important to review it. There's no question now that even not only in our country, but worldwide, non-communicable diseases, obviously despite situations such as the pandemic, et cetera, are now the leading cause of death. And of course, they're also the leading cause of death in our nation, and in not only in South Carolina, but our collaborative states. So hypertension is the leading risk factor for cardiovascular disease. And if cardiovascular disease is the leading cause of morbidity and mortality, it does behoove us to pay attention to hypertension. However, despite all the knowledge, education, and efficacious, safe, and affordable medications, our control rates globally, but also, I will submit, in our country, are dismal. And as you can see, globally, the hypertension control rates are only approximately 20%. That was the impetus for HEARTS. In our country and in our state, we're not doing appreciably much better. And I'm going to go into that in a little bit more detail. And again, this is despite or in spite of safe, effective, and affordable pharmacologic treatments for hypertension, as well as our knowledge about healthy lifestyles. So it starts with the why, but it also now starts with us, each of us as a collaborative and as individuals. We have to start honest discussions regarding how our current policies have not been successful. They've got us so far. And obviously, if it ain't broke, don't fix it. We don't want to replace things, but we still need to consider doing something differently. And we've heard this over and over and over again. The definition of insanity is doing the same thing over and over and expecting different results. Next slide. Well, this is our burning platform. And by our, I mean our country and our locales, if you will. Up until recently, in the early 2010s, if you will, our hypertension control rates nationally were slowly increasing, as represented by our NHANES population periodic surveys. They reached approximately 55-ish% in the survey from 2013 to 2014. However, something ominous happened in the next survey of 2017-2018, and this is pre-COVID pandemic. For the first time in our history, if you will, and our data collection, our hypertension control rates actually declined, and ominously declined to approximately 43 to 44%. Well, some of us thought, in wishful thinking, that maybe this was just a blip, and the next survey, would show obviously a marked increase back to where we were, and unfortunately, that did not happen. So even on our most recent surveys, this has continued. And that's using a blood pressure control rate of 140/90. If we use blood pressure control rates in multiple guidelines, including the ACC/AHA criteria, that control rate would translate to only 19%. And unfortunately, it's not just a number. The reduction in hypertension control rates is at least related or in conjunction with our recent increase in CVD-related morbidity and mortality, especially stroke. Next slide. So this data from the NHANES result and the first appreciation of a reduction in hypertension control rates nationally prompted our Surgeon General out of DC to issue a call for action. And this was right in the middle of the COVID pandemic. Clearly, we could have been doing a lot of other things, but our Surgeon General felt it was that important and that ominous that he issued a call for action. It's on .gov, if you wish, that we had to readdress hypertension control rates. And more importantly, we had to do things differently. And one of the cornerstones of the call to action was to optimize patient care in different ways. And one of those ways was to use a standardized treatment approach, which the foundation and cornerstone was a comprehensive hypertension treatment protocol. You're going to see that that is also the cornerstone and the foundation of HEARTS. Around that, of course, are all the other conjunction and important things we need to do in a comprehensive fashion for patient care, as you're going to see, also is incorporated in HEARTS. Next slide. So that's the burning platform. That's the why. So another component of change is to now reassess our approach. Well, what have we done in the past? Let's not reinvent the wheel. Let's look backwards before we look forwards. Well, even in my career as a physician, I've been through no care. We didn't have evidence-based medicine in the 50s and 60s for the treatment of hypertension. And even if we did, we probably didn't have really safe, effective, and tolerable antihypertensive medications. However, in the 70s and 80s, that changed dramatically, as we all know. The evidence base became absolutely conclusive that lowering blood pressure pharmacologically improves morbidity and mortality. And we developed the step care approach to treating hypertension, which was key, and it was critical at the time. And that step care said, let's use one agent for everyone, a thiazide or thiazide-like diuretic, maximize the dose as a monotherapy. If the blood pressure is still not controlled, add a second complementary drug, maximize it, add a third, add a fourth, et cetera, et cetera. We moved from step care into the 80s and well into the 90s until present time into individualized care. Well, what's the difference? The difference is only that rather than using one medication for everybody, we could select, of agents such as maybe 3 different classes and agents within them as the first monotherapeutic agent to be prescribed. However, the step care approach was still utilized. Use that one drug, maximize the dose, add a second, maximize the dose, third, fourth, etc. I would like to propose, and what we are proposing is now to, and in our concert with change, not only with HEARTS, but our other programs as well, that we really move from an individualized approach to care to a population-based care approach. And that is that we develop a treatment program that treats most. No treatment program is going to treat all, and that still requires individualization of care, but that's the exception, not the rule. And that's what we're going to propose, and what we've been proposing over the Lunch and Learn series is to revisit our present care systems and develop care in a population-based approach that fits most. Next slide. So first, let's look at the barriers to blood pressure control and see how our multiple hypertension control programs, including HEARTS, solves or addresses head-on some of these barriers. There are patient barriers such as limited access to treatment and adherence to prescribed medications. There's provider barriers, of course, the most important of which is therapeutic or clinical inertia, the failure to either initiate treatment or intensify treatment when it's evidence-based and it's obvious and according to treatment guidelines. And there's health system barriers. We're complex, we're big, we're large, we're unwieldy. We have complex medical regimens, etc. And we've been reluctant to develop team-based care approaches. Well, HEARTS addresses almost all, if not all, of these barriers head-on with one component or another, but oftentimes in synergy and integration with our multiple HEARTS pillars, if you will, which we're going to review in detail. Next slide. Well, this is the global HEARTS initiative, and it encompasses three components. Remember, we're discussing now a population-based approach to care. And that population-based approach not only encompasses hypertension treatment, et cetera, and as we're going to see, diabetes and chronic kidney disease, but also a population-based approach has to take into consideration healthy lifestyles. So there's Empower for smoking, there's Active to get moving, exercise, et cetera. There's Shake to limit and decrease markedly our sodium intake, not only within each country, but globally as well. And then there's Replace, a component, if you will, which is to move from saturated to from trans fats to saturated fats. HEARTS is also a health services clinical approach, and that's what we're going to center on today as a summary of our Lunch and Learn series that involves technical pillars and then technical modules, which we're going to review. And all of this is a chronic care model. This is a primary care-based approach, and the end result is, and the why is, we need to improve our dismal outcomes. And obviously we need to develop integrated patient care in a different fashion. Next slide. Well, these are the technical pillars of HEARTS. And we reviewed these from the very, very beginning of our Lunch and Learn series. The pillars consist of standardized treatment protocols, blood pressure measurement in terms of accurately measuring blood pressure in an appropriate manner with validated devices, as we're going to see. Obviously, it includes training and education, data standardization and utilization, and innovation of data analyses. You've got to implement the work that you're developing and the programs you're developing. So another pillar is implementation research on how best to get these programs down to the individual patient in a countrywide or region-wise system. And obviously, we want to be innovative, and we want to have innovation in organization of care. And finally, make a passionate appeal to implement more fully team-based care where appropriate. Next slide. Well, the technical pillars are backed up by individual modules, which is the how-to. How are we going to do these individual pillars, if you will? And that goes by the HEARTS monogram, of course, HEARTS, H-E-A-R-T-S. No accident, right? H is for healthy lifestyles and counseling. There's a whole module on how do we approach healthy lifestyles, which ones, behavioral modification, motivational interviewing, etc. The E module, I'm biased, I believe is the foundation. That's our module that includes evidence-based protocols, our standardized algorithms that should be safe and simple. Also measuring blood pressure accurately, et cetera, with validated devices. A is access to essential medications. You can't treat something if you cannot get the medications or the technology, like validated blood pressure devices, for instance. R is for risk-based cardiovascular management. We'll discuss that further. Clearly, I'm going to say over and over and over again, the T, team-based care. And then, of course, if we're going to develop innovative programs, even at a population level, you've got to measure what you're doing, and that would be systems for monitoring. Next slide. So the pillars and the modules are the background. Well, what has HEARTS done? Well, over the last 10 years, it's been remarkable. As you can see, this is up to, I think, 2021, if you will. There were 22 countries implementing HEARTS in the Caribbean and Latin America. Now we're up to 25 to 28, depending on collaboratives, et cetera. But it's just increasing rapidly every year. And you can see that it's not only increasing in number of countries, but the individual patients that are being covered by HEARTS. I would like to see the dot placed now in the United States in 2023. As you can see, just a little bit above the graph on the left. Next slide. Well, I've already mentioned that the algorithm, the treatment algorithm, which is within the E module, is sort of the cornerstone and the foundation. And when we were initiating HEARTS, you had to start somewhere. And this is what we selected as the first primary approach and the first module to implement and to develop implementation research. And it's been wildly successful. The algorithm is key. It's key to a population-based approach. It's key to a public health approach. And it's very, very critical to a primary care approach. Why? Well, first of all, it's a critical strategy to increase hypertension control rates. It addresses clinical or therapeutic inertia because it tells you how, when, and why. It's straightforward, simple, and standardized. It can be adopted at a local clinic, an individual practice level, if you will, or countrywide, or even regionally, or hopefully globally. There are guiding principles such as it must be primary care based. The algorithm must be for the patient rule, not the exception. That is a population-based approach for most, but it's not going to be for all. There's always going to be exceptions where individualization of care is going to be required and welcomed, but that should be very, very unusual, about 5 to maybe 15%. The algorithm should have few medication titration steps as possible. It should be linear with no branch points. It should use half maximal doses as the initial therapy of the agents that are selected within the classes. And critical to the algorithm is to start with 2 medications at once of complementary classes, again at half maximal doses. Next slide. This shows an algorithm from Kaiser Permanente, our colleagues, and one of our colleagues at Kaiser Permanente participated in our Lunch and Learn system. This shows and it's an example of an algorithm that's been successful. This is in our Kaiser Permanente collaborative colleagues in California. Notice they start with 2 antihypertensive medications at once, an ACE inhibitor and a thiazide diuretic. They rapidly titrate the doses up to achieve maximal doses of each. If the blood pressure is still not controlled, add a calcium channel blocker, maximally increase the dose rapidly. And again, if you're still not under control, there's opportunities to add a spironolactone and now a beta blocker, and their beta blocker is changed into a bisoprolol instead of atenolol. If you're pregnant, of course, and RAS inhibition cannot be administered, then, of course, there's one point that says use thiazide and chlorthalidone together. And then in addition to a calcium channel blocker, as you can see. Next slide. And again, and this has been wildly successful. Kaiser Permanente started their program around 2002, 2003. And as you can see, their hypertension control rates were well below our national rates of 55%. However, upon the initiation of the algorithm and protocol, and system-wide acceptance, notice how rapidly the hypertension control rates increased now to 90%, and they have now been sustained. This is 2013 data, but the recent data shows sustained levels of these blood pressure controls, in addition to marked decreases in cardiovascular morbidity and mortality and outcomes. Next slide. But I think this is an important slide. And this slide demonstrates the importance of, if you're going to develop a population-based approach, your approach needs to be effective in almost everyone. And this shows the blood pressure control rates using an algorithm, starting with 2 complementary medications across a wide range of demographics, whether you're Asian Pacific or Islander, Black, Hispanic, non-Hispanic white, or even unknown, the blood pressure control rates within the demographic populations are equal. This is very, very important as we're going to disseminate HEARTS not only globally, but in our country when we're going to address diversity and disparities. Next slide. These are the early countries that adopted HEARTS: Barbados, Chile, Colombia, and Cuba. And now we're up to, I already said, about 25 to 28. And you can see that they all started with 2 medications at once. They varied the agents, they varied the classes, but the guiding principles was the same. And all of our HEARTS countries are now adopting the exact same approach in terms of their algorithm. Next slide. HEARTS now, of course, has come a long way since its inception of just looking at the E module. Now all of our modules and pillars are in place and now have been developed into this one comprehensive slide that we can have as a poster and put it up in our clinics and our practices. And this is the clinical pathway that was presented by our colleagues and our presenters during the Lunch and Learn series. It has A for accurate blood pressure measurement, B for cardiovascular risk assessment, and C, the cornerstone, the treatment protocol, not only when you start medications or what your targets should be. And this is another example of an algorithm that is in use in many of our HEARTS countries. Again, though, the guiding principles are the same. It starts with 2 medications at half maximal doses from complementary classes. In this case, an ARB, telmisartan, and a calcium channel blocker, amlodipine. Double the dose in 1 step. Add a 3rd agent, a thiazide or thiazide-like diuretic, double that. And then, of course, refer or start a 4th medication as your local algorithms are developed and would guide our practitioners. It also adds other cardiovascular risk treatment assessments such as aspirin and such as statins, when and how to use agents and at what dosages. And more importantly, it includes vaccinations, because we know that vaccinations, inflammatory disease, and cardiovascular disease, unfortunately, are integrally related. And we've seen that time and time again with COVID. And now we've also known it for many, many years with influenza, and we're seeing that again. Next slide. So cardiovascular risk factors are one of the key components of the clinical pathway. And of course, we know the modifiable and non-modifiable risk factors. I do not have to review them for you. We're going to talk about a few just very briefly. But again, HEARTS addresses each of the cardiovascular risk factors and overall risk assessment. Next slide. And why this is so important is it's unfortunate. It's unfortunate that there's not linear increase in event rates with risk factor augmentation and addition. It's exponential, as we all know, as you can see from the original Framingham data from Dr. Cannell. It's exponential as you increase and add on cardiovascular risk factors on top of one another, particularly on top of hypertension. Next slide. So risk factor assessment is important in our clinical decision-making. Number one, it's important for overall health assessment, and we discussed this in our Lunch and Learn series. It also has implications for blood pressure treatment thresholds and treatment targets, as we're going to see. And most of our guidelines for statin use, particularly in diabetes, the dosage or the initial starting dose, the intensity of the dosage also is determined by cardiovascular risk. Next slide. Well, this is the WHO treatment guidelines for the initiation of pharmacologic treatment. What blood pressure threshold? In most adults, the threshold is 140/90 or greater. However, as you can see, those with cardiovascular disease, which is already existing, the recommendation is start at a lower threshold, 130 to 139. But in discussing risk factor assessment, That's the same thing if you have high cardiovascular risk, as you can see, that's highlighted. If there's an individual with high cardiovascular risk, however that's defined and which calculator is used, the starting blood pressure is lower, as you can see by the guidelines. We will also address diabetes and chronic kidney disease, as you can see. Next slide. Well, this also translates to the recommendation that you lower the blood pressure further. Individuals with high cardiovascular risk by assessment. As you can see, the goal, if we're going to start between 130 in the 130s, the goal is to lower blood pressure to less than 130. Next slide. And that has led to one of the specific recommendations from the WHO guidelines, which is absolutely to determine cardiovascular risk assessment where possible, but only if it doesn't interfere with the initiation of pharmacologic treatment. It's still important, on the other hand, do not wait to start pharmacologic treatment when the diagnosis of hypertension is made. Obviously, if risk factor assessment can be obtained on that given visit, fine, or within the next reasonable time, but do not delay pharmacologic treatment. Next slide. We've also discussed in the series, in the presentation, specifically the integration of care between the components of our major cardiovascular risk factors and or diseases, and we had a full discussion on diabetes and hypertension. And the fact that the pathophysiology of these two disorders, unfortunately, is integrally related. One causes the other, and the other causes the first one in a vicious cycle. But also they have complementary and unfortunate pathophysiology. Hyperglycemia affects more microvascular disease. Hypertension affects more atherosclerotic disease. These are not mutually exclusive as it is, but they coordinate down and fall on the blood vessel and the vasculature, unfortunately, at the macrovascular and microvascular level. Also, the treatment is completely integrated. Healthy lifestyles are important and integral in both. Glycemic control and blood pressure and lipid control go hand in hand. And we discussed integrating our care of our patients with diabetes, with hyperlipidemia, and hypertension in one of our presentations in depth, if you're interested, or if you actually attended as well. Next slide. That's the same thing with chronic kidney disease. And we also then formally addressed chronic kidney disease, screening and early management in our series. Similar to diabetes, chronic kidney disease and hypertension are pathophysiologically integrated hand in hand. Hypertension leads to chronic kidney disease, and the development of chronic kidney disease either leads to or further worsens hypertension. So thus, it's important for all of us to screen for chronic kidney disease via serum creatinine and developing an estimated glomerular filtration rate, and also to assess urine albumin. Again, not to get in the way of pharmacologic treatment, but in addition to pharmacologic treatment. And of course, if CKD and hypertension are present, similar to diabetes, the pharmacologic treatment thresholds, blood pressure thresholds, and goals are lower. Next slide. And I'll just reinforce that again. If you have chronic kidney disease or diabetes, the initiation of antihypertensive medications is between 130 and 139 systolic. Next slide. And the target is obviously going to be lower. It's less than 130 in individuals with diabetes, chronic kidney disease. So high cardiovascular risk, diabetes mellitus, and chronic kidney disease individuals, not only are they all integrated with one another, but they also fall in the same category of more intensive blood pressure initiation and also blood pressure control. Next slide. And again, let's conclude or summarize with racial disparities. We have known for many, many decades that blood pressure or cardiovascular disease affects age, gender, and race differently. Unfortunately, all of us are going to age, so we're all going to experience increasing cardiovascular prevalence, disease prevalence with age. As you can see, all these curves go up the older you are. But on top of that, however, males, of course, initially have higher prevalence of cardiovascular disease. This is first myocardial infarction data, for instance. But unfortunately, our Black population, our Black individuals, have even higher prevalence of first myocardial infarction, be you male or female, in reference to similar genders. This is what we've all been known, and this is what we now confront and have to address head on. Next slide. Well, since myocardial infarction is age, gender, and race related, would be no surprise that hypertension is too. And in fact, these graphs could be overlapped and put upon each other easily. Again, be you male, female, black, or white. Males greater than females, black men or black women greater than comparable white men and white females. Again, staring us in the face, our race, and we could put other ethnicities on top of this as well. But this needs to be addressed, and we discussed that in our Lunch and Learn series as well. And I've already mentioned that an algorithm that uses complementary medications at half maximal doses at the first step and maximizes those doses eliminates at least the blood pressure reduction and control rate disparities. And it does that on a population-based level. So why not do it? Next slide. And finally, we discussed that HEARTS doesn't live in a vacuum. HEARTS is a component of many other organizations, global organizations within our own country that all are seeking the exact same end result, starting with the same why, trying to improve blood pressure control, integrate control with other cardiovascular disease states. We mentioned diabetes and chronic kidney disease, but even in our own country, the American Heart Association, the Centers for Disease Control, et cetera, are all components and stakeholders within HEARTS. Next slide. So let's conclude. This is a busy slide, but I hope that if you want to go back to it, you can read it. But this was some of the current key concepts and tools that I took away from the Lunch and Learn series. Again, starting with the why, to improve hypertension control, and the outcome, which is to improve patient care and patient morbidity and mortality. So what I took away from this, and this is the Don DePetty take, is that HEARTS in the Americas is a comprehensive blueprint that crosses a spectrum of populations. It's a population-based approach, and as such, it must treat almost everybody. And thus, it is a blueprint for treatment across economic, geographic, racial, ethnic, and cultural disparities or differences. It's one size fits all for most. The others are the exceptions and obviously are treated individually, and that's a wonderful thing within our systems. The foundation of HEARTS is the use of a standardized, simplified pharmacologic protocol to treat hypertension, which uses, and I want to emphasize, which uses 2 medications upon the initial diagnosis of hypertension at half maximal doses. HEARTS develops a primary care approach for the treatment of the patient with hypertension. And that means it's for the patient rule. There's always going to be patient exceptions. It outlines clinical drivers and critical clinical drivers of hypertension control. Many of those have already been incorporated into our cardiovascular risk assessment and our hypertension clinical pathway for the management and treatment of hypertension. It works. It integrates the management of hypertension, diabetes, and chronic kidney disease, among others. The launch of HEARTS in America can significantly improve the detection and treatment, and importantly, the control of hypertension. It is doing this in the Caribbean. It is doing this in Latin America. It is doing this in other countries globally. It absolutely is appropriate, effective, and addresses many of our needs, not only in our own 4 states, but in our country as a whole. And it's a population-based approach that crosses our demographics. And finally, HEARTS in the Americas is in addition to, and it's complementary to programs that are already in place. Many of the countries in the global initiative have no program in place. So HEARTS is the foundation, if you will. We already in our country have other programs that have been effective, et cetera, and work. And HEARTS is a complement to those programs. So if we're already using those programs and they're being successful, that's good. Let's layer the HEARTS programs, et cetera, and perhaps it fills in gaps, et cetera, or can move us forward even more rapidly with programs that are already in place.